Okay, so good afternoon and welcome everybody. This is the highlights and best of Bowes session. So it's the penultimate session of the week. I think it's been an absolutely fantastic Bowes 2019. There have been amazing things going on throughout the whole conference, and I really think that one of the things that we've done very well this year is just the extracurricular topics we've covered. We've covered innovation, we've covered burnout. We've covered academic publishing. There's been some really strong Bowes section of trainees sessions that have been absolutely excellent. We've had fantastic guest speakers, and in this auditorium itself there have been some great things going on, including a universally challenged, or university challenged as they call it, university challenge. We've had Il Divo on this stage on Monday night, which you have to be a certain age and gender to know who they are, but world famous singers. Not part of Bowes, but I'm glad I'm sharing the stage. They were standing right here. And we're going to carry on today's session with highlights of the separate sections of andrology, oncology, female and stones, and endourology. So I'm very pleased to introduce all our speakers. If I can have the first slide. So we've got Mr. Will Finch, who's going to talk to us about endourology, and I'll invite him to the stage in a moment, who's a consultant at Norfolk and Norwich Hospital, and he specialises in stones, HoLEP and upper tract laparoscopy, followed by Mr. Krishna Narahari, who's an oncologist. He's currently working in the University Hospital of Wales in Cardiff, who specialises in prostate, kidney cancer treatment, including robotic surgery, and is the current secretary of the Bowes section of oncology. And Ms. Ayo Kalijayi, who is our andrologist today. She works in University Hospitals Birmingham, and she specialises in andrology, infertility and uro-oncology. So if I can kindly ask Will to come to the stage, and we will start with endourology highlights and the best of Bowes. Thank you.
So, good afternoon, everybody. I'm going to take you on a gallop for the next 15 minutes through endourology over the last 12 months. And a big thank you to everyone from the section of endourology for putting together what's been a great program. And we'll touch in the second half of my talk on some of the highlights as I've seen it and the take-home messages from those endo sessions. So in terms of the world literature for the last 12 months, it's quite daunting to look at it. And Professor Neil's talk yesterday I particularly liked when he told me there was 168 indexed urology journals. And I can promise you I haven't looked at all of those. But here is my highlights of stones and BPH. This is a study which we talked about at the RSM meeting earlier in the year. This is Andy Portis, and it's a study which published in the BJUI this year where he looked at the world of passing stones post-tamsulosin. And the take-home messages here for me are that with patients, with excellent information, telling them what they're going to be doing, excellent analgesia, and optimizing the process and the pathways and who to contact and their follow-up around them. In the States, they encourage more people to pass their stones, but more importantly, in those people passing their stones, the intervention rate for surgery dropped from 26% down to 20%. And overall, they noticed a significant reduction in surgical intervention with supported stone passage. So the take-home messages for us is that I think we can do probably better with our patients who are on medical management of stones. We don't use tamsulosin, but we can work really hard on patient information and supporting these patients and giving them the best chance of passing stones. So those with renal stones, the asymptomatic renal stone, something that we all see in our clinics on a weekly basis. This large study from China looks at 10 years of retrospective data with a mean follow-up of just shy of 5 years. But what it gives us is contemporary, up-to-date information on what happens with people who we're watching renal stones. It gives us some up-to-date data on the likelihood of them passing that stone at about a third of people, stone growth in about 16%, developing stone symptoms in a further third. But interestingly, a low requirement for intervention at 12%. In their multivariate analysis, they go on to look at reasons why stones may grow, and in groups of people that's more likely. But some really up-to-date data that we can use in our clinic next week with this group of patients. The negative ureteroscopy, we've talked about that here over the last few days, and some units are very lucky to be able to have on-the-day imaging or imaging in the few days before surgery, but it's certainly not widespread practice. This study, published in JEndoUrol last year, looks at clinical parameters in which our index of suspicion should be elevated for people who are likely to have a negative ureteroscopy. It's really important that we know our negative ureteroscopy rate. In this paper, it's 3.8%. And they suggest that in women, the negative ureteroscopy rate is higher. In stones you can't see on plain film X-ray, and also small stones. This is the group of the people that perhaps those of us who don't have on-the-day imaging should be pushing to get imaging to reduce and minimize your negative ureteroscopy rate. We've done a lot of work in the section with our registry looking at infection, and this is another Chinese study trying to identify and predict who's going to have a post-op septic complication after PCNL. A nice study with a post-operative sepsis rate which fits with our experience in the UK and our registry data. They've identified from multivariate analysis some independent risk factors, and the real take-home message for me is the operating time. And operating over 100 minutes is significantly associated with the likelihood of a septic outcome, and that's a real take-home message from this paper. We've had discussions about the role of urine dipsticks and predicting infection, and I think the operative group are different to the group being looked at by NHS England at the moment. But positive urine dipsticks, likelihood of a septic complication, positive urine cultures, positive stone cultures, all associated with an infective complication afterwards. So the take-home message: we need to identify these patients with positive urine dipsticks, make sure we're absolutely happy that we've treated and minimized their risk of infection before we operate on them. So moving on to outcomes from surgery, there's been a theme at this meeting, and there's a theme in the literature that our traditional approach with plain film X-ray underestimates really the amount of stone left after an operation. And there's a drive to image people with CT, and this nice study from urology has a sort of contemporary series to what we see in UK practice with an average stone size of 6 mil. They use a lot more access sheaths than perhaps we do in the UK, but a mixture of dusting and basketing. And a CT at 3 months follow-up shows a 0 fragment stone-free rate, so absolutely stone-free in 73% of people. And I think this is really interesting because it's data that we should perhaps be quoting now and looking to see how our data and being honest about what follow-up methods for imaging we should be really using now that we know about a bit more about radiation doses and the role of those in follow-up. So outcomes from PCNL: if you do your PCNL, visually you look around the kidney, you use fluoroscopy, and you're happy it's stone-free. But is that really stone-free? This study asked surgeons to classify at the end of the procedure, was the case stone-free or insignificant residual stones less than 4 mil, or was there significant stone burden? And in cases where the surgeon felt that he got them stone-free or near as he could do, there was still nearly 20% of cases had significant stone burden. More likely to be a problem in the multiple stone patient or in stones with or the larger stone burden. But I think this is interesting, and the take-home message for me here is that we need to think about these multiple stone patients with large stone burden and perhaps imaging them sooner so that we can then plan adjuvant strategies to get them stone-free. Once we've operated on people and got them stone-free, who's going to require surgery in the future? And this is a paper in Press in the BJUI, which looks at a group of people who've had stone surgery with nearly 5 years of follow-up. Yes, 60% of people have had stones before, but what they looked at was people who formed new stones in the same kidney or new stones in the contralateral kidney, and that happened in 25% of people over a 5-year period. So nice data, contemporary data, which we can use to educate our patients about the risk of stone recurrence in the future. They've identified reasons for people having repeat surgery, whether it be pain, stone size, infections, blood in the urine, or asymptomatic obstruction. And they've also, through multivariate analysis, identified in people or risks which increase people's risk of surgical recurrence. All of those, interestingly, have the same weight attached to them, and they've moved on to suggest that you can sort of risk stratify these people into low, intermediate, or high risk of stone recurrence. And this, I think, sort of sets us on a journey whereby we should be looking to risk stratify our patients for future stone events, which may then allow us to risk stratify their follow-up or investigations or further metabolic treatments potentially. And my final stone slide from the literature, we've heard a lot in recent times about the debate of single-use and reusable flexible ureteroscopes and whether they work, whether they're equivalent, and when to use them. This paper tells us about infundibulopelvic angle, and the narrow infundibulopelvic angle is important. Their breakage rate in this series was about 10% for their reusable scopes. But a narrow infundibulopelvic angle predicts flexible ureteroscope damage, it predicts Clavien Dindo 2+ complications, and it predicts prolonged hospital stay. And so for me, perhaps we ought to be looking from our pre-op planning CT for this angle. And if the angle is less than 55 degrees, it perhaps guides us, for those of us who do have single-use scopes, to use a single-use scope to protect my reusable scope, but also hopefully avoid complications and avoid a prolonged hospital stay. So BPH. The theme I got looking at medication-related papers is that we're all very comfortable using tamsulosin and 5-alpha reductase inhibitors, which I'll talk about shortly. But there's been some literature reviews and some editorials in the American literature suggesting that now these patients of ours have been on these medications for a long time. Actually, there are some slightly worrying side effects beginning to be noted. So admittedly, these are cohort studies, and that all has limitations. But in this paper, they suggest that tamsulosin may be associated with a higher risk of dementia. And in this paper, looking at dutasteride therapy, again, a registry retrospective study, but potentially associated with diabetic changes, liver function changes, cholesterol changes, as well as testosterone and ED changes that we're all well aware of. But for me, this changes the conversation that we perhaps should be having with patients about moving away from that traditional medication and then surgical approach to BPH and having that conversation with the advent of minimally invasive therapies much earlier, especially with this knowledge that perhaps there are some side effects that we haven't previously been aware of. There's a number of minimally invasive BPH techniques. Urolift and the Cochrane review of Cochrane collaboration have looked at this and reported on this recently. Resume, we've seen this data presented here earlier in the week, showing 50% near improvement in IPSS, quality of life, and flow with a low surgical retreatment rate at 4 years. Aquablation. This paper from the BJUI this year in Press looks at large prostates, which shows that they do have improvement in IPSS and flow, but again, there continues to be a high intervention rate for hematuria and complications associated with it. But a nice study in patients with large prostates, which is important and relevant to everyday practice. We've seen this study presented earlier, was part of this study presented earlier in a poster session, and the UK registry of prostatic artery embolization reported last year in the BJU, and again they've shown improvement in IPSS, not as much as TURP, and a reoperation rate and some complication data associated, but an option and a minimally invasive option for men, and something certainly to discuss. I'm an advocate as HOLEP, as you've heard, and this paper caught my eye in JUROL this year, a large number of patients who've been followed up for the longest follow-up, 18 years, but now 10-year data showing that men continue to be pleased with their flow, pleased with their symptom scores, and with a low complication rate from surgery out at nearly 10-year follow-up. And for me, that's very reassuring for HOLEP and durable long-term outcomes. So that's the literature. And moving on to the meeting, I think it's been a fantastic meeting. There's a lot of hard work and effort from a lot of people go into getting the endourology program together. And for me, there's been a real theme of quality improvement and some novel research. And in the first poster session, this study by Ben Turney and his group in Oxford, looking at their biobank of stone formers and collaborating with a group in Japan. And they did a huge GWAS study on these well over 400,000 patients and identified 10 novel genetic foci associated with stone disease. And this is really exciting and the first step in potentially a journey whereby people can have a personal risk alleles identified for stone disease. And if these risk alleles have got pharmacological or interventions for them, we can potentially in the future pick the reason that people have stone disease and intervene and reduce that risk for them. This study from Salisbury looks at the dose that we're giving our patients with plain film X-ray and CT. And whilst it did generate some controversy about the effective dose associated with a plain film, it makes the point that we need to know how much radiation we're exposing our patients to. For patients of my size, it appears that we're getting a higher effective dose in this study with plain film than CT, and therefore perhaps we ought to be using CT more in that group of patients to minimize the radiation risk and also optimize and make sure we know what the stone burden is we're dealing with. This study looks at stents. It's a study that's been performed in Cambridge with Ollie Wiseman and Olivier Traxé, and is a randomized control trial looking at a silicone stent from Coloplast and comparing it with a standard stent from Boston Scientific, the Percuflex Plus. They show that using a validated symptom score, the USSQ, at day 20, there's significantly less pain with a silicone stent. They also show that there's significantly less encrustation with a silicone stent. And the take-home message here for me is that silicone stents appear to have advantages for the patient for medium and long-term stenting. Any patient having a stent less than 20 days, we're not going to see that advantage, but a nice study with a clear message. We're very lucky to have Professor Khurshidgani over from Michigan, and he gave us a really fascinating talk. The first half of it concentrating on laser energy and the effects of that energy on a stone, and giving us a real in-depth understanding of how we should be using our settings to achieve various stone ablation fragmentation techniques. And for me, the real take-home message was that, manipulating and changing your laser settings as the stone characteristics and size and composition of your fragments change throughout the procedure. And your laser settings are a very dynamic thing during a procedure. And the second half of his talk focused on quality improvement and explaining that the emergency department visit rate really is an emerging quality indicator for ureteroscopy and colic pathways. And he showed us areas of good practice and quality improvement that they'd used to improve that process. As part of that, in the UK, we have the BURST Collaborative, and Nikita Bhatt, who's a trainee in East Anglia, in the Dragon's Den BURST session last year, had a nice project about identifying how long we should be leaving stents in our post-ureteroscopy patients. And it's really nice to see how that's progressed, and that study has a number of different platforms ready to go with it. And I would encourage you to fill in the survey on the BAUS app from the Monday afternoon session to look at the take-up and help contribute to that, so that BURST can move forward with what's potentially a really exciting stone study to be done in the UK. So just finishing up, we had a very nice session on the NICE Stone guidelines yesterday. And the take-home message for me really was that if we're going to try and achieve stone treatment for ureteric stones within 48 hours of presentation, for the vast majority of the UK, that requires significant service reconfiguration. And to achieve that, there's been some quality improvement projects presented over the last couple of days. And this looks at the effects of networking and units coming together and a small DGH joining forces with their stone pathways with a large teaching centre. And it shows that with collaboration and working together, it's produced a reduction in treatment time for that small DGH by nearly 30 days, and also a reduction in the actual number of patients requiring treatment. So working together, sharing pathways has had a positive effect on the patient journey and the service that they're offering. Lithotripsy is what we should be aspiring to according to the NICE guidance for small ureteric stones, or stones less than 10 mil, shall I say. But that's not on offer to everybody. But what is on offer to most people is the ability to do ureteroscopy, albeit not in an emergency setting. And this study from the Wirral by James Glendenning's group shows that actually if you do concentrate and look at your processes, that primary ureteroscopy can be delivered in 3/4 of the time on the same day in collaboration with your middle grades in a safe environment with a low complication rate. And then finally, my final slide is best poster from yesterday. It's got one of the most complicated graphs I've seen on it in a poster session before, but a really important clear take-home message. In people who have ureteric obstruction, who we are intervening in, for the majority of people, we are not improving their renal function. We're merely stabilizing it or protecting it. And in Darren's group here from UCL with his colleagues, for those with malignant obstruction and for those with very poor renal function, that means a conversation about quality of life implications for stents and for nephrostomies and intervention if it's actually not going to improve poor renal function. But a very nice study and one that's got a clear take-home message. So thank you very much. It's been a fantastic BAUS. Thank you very much to everyone who's helped me put my slides together. The future is bright for endourology. There's a lot of hard work, a lot of exciting things online and coming online. So thank you very much.
Okay, thank you very much, Will. That's excellent. I think the take-home message, because this session is really to help people that aren't necessarily subspecialising in stones or any of these other aspects that we're talking about today to really keep up to date with things. And I think the take-home message is that this kind of information is going to help us know what our stone-free rates are after flexible ureteroscopy and after PCNL and really counsel patients. And I think the idea of risk stratifying patients is excellent. And in my own practice, I'm going to have to think about using silicone stents for my reconstructive patients because they have stents in for more than 20 days sometimes. And also this push for primary ureteroscopy really is an emergency rather than always putting stents in for patients. I would like to invite questions, please. We've got 4 mics on the floor. Please don't be shy. This is your time to ask. And also, we do have the app as well. So if you want to use the app to submit questions, I'm happy to do that as well. Any questions? Yep, so mic 4, please. Sorry, I can't see who it is.
So it's not use the word middle grade. You're no longer supposed to use that word. It's SAS doctors.
So I apologise. A slip of tongue. It wasn't meant to be derogatory in any point, but those supporting that area of on-calls, and there's a variance in roles and what they're called across different organisations. They're incredibly important, and the real take-home message from that piece of work from the Wirral is actually engaging and supporting your team to help with delivering this care and supporting people to do support acute treatment for ureteric stones in a safe, supported environment with your team around you. So no offence was intended. They're very, very, very important members of the team.
I think the only other comment I'd say is the HOLEP data at 18 years is very interesting. We're starting to see more bladder neck contractures and urethral strictures coming through from bladder outflow surgery, and HOLEP had been something I'd been noticing, but in fact a rate of 3.5% over an 18-year study is not too bad. It's pretty good.
So we've got a reasonable experience of HOLEP in Norwich, and it's always a concern, especially with the smaller prostates, but it's not something that we are seeing, and actually that data slightly sort of reassures me with that. But I think we need to follow our data for longer.
All right, thank you very much, Will. So I'd like to invite Krishna to the stage. He's going to give us an overview of oncology. I think things are getting very interesting. The role of immunotherapy for urothelial carcinoma is a very interesting development. I'm keen to hear about more about it. So Krishna, if you'd like to make a start.
Just checking. Thank you, Suzanne. My whole adult life, I've religiously and meticulously gone to a dentist every 6 or 12 months as advised, paid £20 or so as instructed, to be told that I have 32 teeth, which my 7-year-old can do just as well. However, on Monday evening, I found myself in that place with a very painful tooth. And then this, and this, and then this was offered to me for a dental abscess. So my sincere apologies. I have not been able to personally thank all the people who've presented, chaired various parts of the section presentations, and the audience who've come to the meetings to make it a success. Believe you me, I'd rather be with you in the evenings having that rather than settle for this. But such is life. So the talk is about highlights of BAUS 2019 and highlights of the year. It is daunting, as Will said. There's so much literature. And if one message I could take away is there's no p-values here, but there are p-values, as in Neil Spenceley's talk about the person value. Hopefully that's my ending note. So I'm going to break this down into highlights of the year and highlights of BAUS 2019. And I've just picked 3 things in the 3 main cancer areas, which I think are relevant to British urology and have some futuristic value. So, prostate cancer. We have to talk about the NICE guidelines. I think PROMS, the NPCA PROMS and PREMS is excellent data, real-world data that we should talk about. And STAMPEDE, that is a game changer and will continue to be so. So, the NICE guidelines were published after a consultation in May of this year. And there are lots of changes, but the main ones being pre-biopsy, multi-parametric MRI, and MRI-influenced systematic biopsy, hypofractionated radiotherapy over 4 weeks as opposed to 7.5 weeks, which is already the standard of care in most places. Chemotherapy in metastatic prostate cancer upfront, but also considering it in high-risk non-metastatic prostate cancer, and ABI and ENZA in post-chemo setting. Second point, the National Prostate Cancer Audit, the PROMS and the PREMS. Now, this is the only national data set that focuses on PROMS and PREM outcomes in prostate cancer treatment, not surgery, treatment in the UK. For that reason, I think this is highly, highly valuable. And in the section of oncology meeting, we have the pleasure of having this as a breaking news session where Professor Clark and his team come along and give us the annual report. And we hope there will be one such report in the November meeting. So infographics are excellent. We know now that we are treating far less low-risk prostate cancer than we were before. We are treating more high-risk prostate cancer, as we should be, than before. And look at this, 90% of patients are generally happy with the care they've received. That's excellent to know, I think. And some real-world data on urinary continence or incontinence, potency, and bowel dysfunction. And I think this is important for us to be able to either show this to patients in the clinic or at least have an honest discussion to say 2 in 10 men after surgery will be wet requiring a pad. Does not necessarily mean they need a sphincter, but they will be wet requiring a pad. And that a majority of all comers, only 20% recover their potency. If you super select out the young, the fit, the low-risk disease or lowish risk disease, excellent nerve sparing, yes, you can get potency rates higher up. But in all comers, it's about 25%. I think it's important to reflect on this and be honest with our patients about this. And then there's, of course, STAMPEDE, which is a game changer. Now, this is the STAMPEDE M1RT data, which has clearly shown that in low metastatic burden or oligometastatic disease, however you choose to define it, less than 5 bone mets, less than 4 bone mets, no visceral mets, pelvic-only disease, etc., there is benefit to local treatment to the prostate with radiotherapy. And that has been also assessed in a meta-analysis, the stopgap meta-analysis, which agrees with the same result. And this has particular relevance to the surgical fraternity, because there may well be a role for a prostatectomy in oligometastatic prostate cancer. And we know the trombone in the UK, G-RAMP in Germany, and SIMCAP, so the 3 randomized controlled trials trying to assess the role of prostatectomy in oligometastatic or low metastatic burden prostate cancer. I think in the next few years we will see this, because surgery offers the opportunity to know the cancer better at a molecular level and hopefully then treat the systemic disease better, potentially. As far as kidney cancer is concerned, in the world literature, there's a couple of interesting papers, presentations in AUA this year. We have to talk about Carmina, a bit like we have to talk about Kevin, and the IBS and the MABS, which is a minefield in itself. So I just picked out these 2 papers relevant to partial nephrectomy surgery. One was by the MSKCC group, and the other by the Canadian group, 6 centers in Canada, assessing in a randomized control fashion the benefits, or not, as the case may be, of renal hypothermia and mannitol in partial nephrectomies. Interestingly, in the hypothermia group, they included all patients, including people with poor renal function preoperatively, and found that there was no significant difference in long-term GFR. And similarly, in the mannitol group, there was no difference. So if any of us still carry on doing ice slush cooling or use mannitol pre-clamp, I think we have to think about it once the manuscripts of these become available for further scrutiny. Secondly, Carmina. So now this, it has been a big paper, and there are lots of criticisms of it, but essentially the Carmina said there is no benefit or no role for cytoreductive nephrectomy in metastatic renal cancer. But we know that this has lots of deficits, and I'll just stop at this stage and come back to it again, if I may, because there's some very good local data presented in this meeting that proves this is not at all the case in the real world. The second point is the IBS and the MABS. I make no apology for this slide being busy. You could pretty much put an IB or a MAB to any word, and that is a drug for renal cancer. Now, a moment of reflection here is, should we as urologists be managing these patients with advanced disease? We've been at this juncture before with urogynecology and female urology, and the gynecologists ran away with that. Or with prostate cancer systemic treatment management, and the oncologists are running away and have run away with that. And I think we're again at that juncture. And it's really for us to think about, what do we want our trainees in the future to do? Do we want to be managing advanced disease, or do we want oncologists? Is it that this train has also left the station? It's something to reflect on, I think. As far as urothelial cancers are concerned, I just picked out 3 interesting areas. VIRATS was presented in the section meeting last year by Jim Cato and team. It's quite exciting. It's early, it's in development, but it could be the game changer in prostate cancer, in bladder cancer diagnostics, like MRI has been in prostate cancer. We don't know results for this yet. Like I say, this is in development, but this is very interesting stuff. POUT was presented here and in the ASCO and the ESOU meetings, and the take-home message from POUT really was that there is clearly a benefit, a survival benefit, for adjuvant chemotherapy in high-risk upper tract urothelial TCC, which I think is practice-changing. And finally, again, advanced bladder cancer treatments. Look at the number of trials assessing various agents in various combinations in advanced metastatic bladder cancer. What's most interesting about this is a lot of these trials are now also assessing this in high-risk, non-muscle invasive, non-metastatic bladder cancer that can't be treated with a cystectomy because the patient population is not fit. So until now, we've really had BCG or various versions of mitomycin or the epirubicin or certain other agents only for this group. There are currently ongoing trials assessing the role of these agents in non-metastatic, high-risk, non-muscle invasive bladder cancer. And that, I think, will be a very interesting development for the future. So, moving on to BOWS highlights. Well, we talked about Carmina and its deficits. There were two excellent papers. The one on your left is the paper from Guy's, and the one on your right is the paper from Newcastle Group, David Thomas and Tim O'Brien's group, respectively. And showing that Carmina does not somehow reflect real-world urology nephrectomy practice. And I think we all know, even our own oncologists agree. And I think the take-home message with cytoreductive nephrectomy is in the suitable patients with either low or intermediate metastatic burden, cytoreductive nephrectomy certainly has a role. Look at these survival results here as opposed to the Carmina. So this is Tim's team with the Guy's cohort versus the Carmina cohort. And look at that survival benefit. So there clearly is a role. And I think if anything, it actually proves that we are selecting out the right patients to be doing cytoreductive nephrectomies on. And I would urge you to enter your data to the BOWS snapshot audit that is currently ongoing. And we may have some further updates in the November meeting. So please do come to that. The other point I noted is the renal cancer session was meant to be renal cancer testis and sarcoma. We didn't have a single abstract in sarcoma or testis cancer. So there's a message to send out to our trainees, our departments, to say that's a good area to do projects on and submit to BOWS. So it'd be nice to see some local work in that area. Bladder cancer, we had two very good quality randomized trials, the Caliber and the Selenibit trial by Rick Bryan's group. Although the trials in itself are negative, there was some useful data to know. And then the Identify study. This is fascinating stuff. Look at that. Nearly 10,000 patients who presented with hematuria, non-visible and visible, and the incidence and prevalence of bladder cancer, upper tract cancer, prostate cancer in that group. And this is only possible because of the BOST Collaborative, and that is just mind-boggling stuff. There's no way without that international effort you would get these many patients into a trial, into a prospective sort of cohort study like this. So I think this is going to inform future practice without a doubt. In prostate cancer, I picked this out. There was a poster on whether or not anti-incontinence surgery should be centralized. But the key message for me from this was the time to anti-incontinence surgery post-radical prostatectomy is 3 years. That is very long to be wet and miserable. I'm a prostate cancer surgeon myself, and I think there's a lesson here for us to learn. If we make people wet as a result of surgery, which happens, we know there is an incidence of severe incontinence after radical prostatectomy, we need to fast-track them through with our reconstructive colleagues to get their quality of life back and to get their misery out of the way, if you like. And I think that is really crucial. That's a big, big take-home message from me. So the next time I find somebody who's quite wet for surgery, I'm going to knock on the door of my reconstructive colleague to say, look, this man's likely to need a sphincter. Can you please see him sooner? This is UK data based on HES. It is not a registry data. So I think it's quite important, and it certainly is a message for us to take. For Vincent Glanaprakasum's group presented 2 papers on the PREDICT prostate cancer tool, which is quite interesting and certainly useful in counseling people with low and low intermediate risk disease, even in high risk disease, by showing them certain tools. And I used this tool yesterday and the day before to showing them the risk of morbidity with surveillance versus radiotherapy versus surgery. So I'd encourage you to at least look at it, because you can use this in patients to visually show them what it is that they're likely to get as a side effect from treatment, which may then influence how they choose what treatment they eventually decide to have. We had an excellent trainee session, the BSOT session and the BURST session. We've talked about this before, and I think the power of this, if you look at the number of trials, the DETOR, the PROPEL, the IDENTIFY, the MIMIC, it's just fantastic. And then that was topped up by a very entertaining and thought-provoking, I think, and a candid talk by Adam Kay, which I thought was really, really fascinating and interesting. On Monday, there was an excellent session I went into, led again by Tim O'Brien, about clinical leadership. And I thought when I go in there, I'll see mainly older folks and who are towards the end of their career. Quite the opposite. It was a mixture, and it's about more collaboration and networking. And I learned a lot from this, only as an observer. And I'd encourage you to come along to this in the future. Angie Smith from the USA gave us a great talk on sarcopenia and rehabilitation, and was ably assisted by Jagdeep Desi about assessment of the frail and the elderly, which was fantastic, I thought. This morning's lecture on innovation in the clinical entrepreneur program, and the chap, I think from Devon, who was talking about using watercress to treat nappy rash in children. And that's, again, this is mind-boggling stuff, but I thought was really, really good. I think this is what makes BOWS special. There is science, there's lots of Kaplan-Meier curves, there are lots of p-values, lots of hazard ratios, but to balance it out, there is real world, there's a person value here. And this is really, really good, I think. And we had an excellent session on advanced cancer from Professor Alex Motry, from Professor Dean Harris, Paul Cathcart, and Matt spoke very well about the Bill Turnbull effect. And talking about Bill Turnbull, his talk I thought was delightful. Very honest, but very, very entertaining in a way. The Atlantic Seamen, again, their talk was inspirational, and so was Adam Kay. I think to top it all, there was quite something insightful here. In our president's address, I learned that urologists have the highest rate of burnout. And Adam Kay made a very good point. He said, look after yourself and look after your colleagues. And I think we need to do that better, because for some reason we seem to have the highest burnout rate. Finally, to top it all, the highlights of BOWS Oncology for me has been that the best trainee in urology this year, Viru Kasi, the best trainer in Herman Fernando, the best young urologist, Ben Chalacombe, and the best senior urologist, Alex Motry, are all oncologists. Thank you.
Okay, thank you very much. So take-home messages again from me is making sure I'm up to date with the nice prostate cancer guidance. I've read half of it so far. I'm going to do it. Predict is doing excellent things, and I would encourage everybody to use that as a prostate tool to give your patients more counselling about their possible outcomes. And for next year, we need some testis, cancer and sarcoma abstracts, please. But my question, if I'm going to kick it off, and if anybody else would like to submit questions or come to the stands, I agree. So I'm a functional urologist and I deal with male incontinence, and at 3 years I'm surprised it's not longer. It takes that long for patients with incontinence to present. I think ED is dealt with excellently after radical prostate surgery, but incontinence has been forgotten. Your practice is going to change, but how can we make it change nationally so that patients can access these kind of treatments sooner?
I don't know is the honest answer, but I can't explain why it is 3 years. Why should it take 3 years? We know if they're really wet in 6 months, they will be wet for the rest of their lives, if they're really, really wet. The old explanation of they'll get better as 12 and 18 months happen doesn't really apply in certainly the local PROM data that we have in Cardiff, or it doesn't bear, it's not applicable anymore. So I can't explain why it is 3 years. Whether you have very long waiting lists, and maybe the section of reconstruction and oncology, we need to work together to make this better.
It's not a waiting list. I think it's patients are relieved they've been treated for their cancer. They then get offered treatments about their ED, and I think the original BOWS audits concentrated on erectile function, maybe less on incontinence. And I think it's something that's not talked about. So I think it's maybe education rather than necessarily kind of waiting to be referred on. Can I take any questions from the audience? Or if not, we'll look at the app.
So feel free to send us questions via the app. I've just got one question, if that's all right, Krishna. So you presented the POUT data and adjuvant chemotherapy for that group. What's the trial that next needs to be done for upper tract TCC?
What's the
trial that we need to be doing next for upper tract TCC?
Well, it's interesting. I asked this question of Alison Birtle, and in particular I asked her whether there's going to be a role for neoadjuvant chemotherapy in high-risk upper tract TCC, like we know there is in bladder. And I think that there will probably be a role. It's trying to select the right patient group. And her response to that was that they only want high-risk group, and that you can't necessarily say that from imaging. But I think imaging is getting better, and we can generally predict who's likely to have a high grade or a muscle invasive upper tract ECC. But I think there is an opportunity to do that.
So we've seen some discussion in the endo section about the role of biopsy and with the Guy's subspecialist MDT for upper tract TCC, but the role of a biopsy does give you reassuring data on grade, which may actually then allow you to predict who's going to have high-risk disease and who may benefit. So perhaps there is a role for biopsying everybody to pick out that group.
Absolutely.
Okay, thank you very much, Krishna. And I'd like to invite Io to the stage now, and she's going to talk about andrology. And I think the andrology section should be commended for the work they've been doing. The recent consensus guidelines on genitourethral emergencies are excellent, very comprehensive, and have been very insightful for our trainees and my colleagues, and very, very helpful. I think also interesting new innovations in the treatment of Peyronie's that have been going on this year and have been presented at BAUS. But thank you.
Good afternoon, everybody. Thank you for inviting me to give this talk. I'm going to do a very quick run through the highlights so far. I'm going to try and cover as much as I can. So I'm going to look at benign andrology to start with. There was an abstract that I thought was quite curious from the Royal Free Group, where they've designed a website and an app which allows patients to go on the app and identify their sexual dysfunction, and then it provides them with advice. We know that Viagra is now available over the counter, so this is really useful for patients where the app can give them advice to go and actually just buy some Viagra, which actually I'm still seeing a lot of patients in my clinic where they haven't been tried on any PDE5 inhibitor at all. So this is empowering patients potentially and hopefully reducing some of our waiting lists so that we're seeing patients who have had at least first-line treatment before they even go to the GP. And the study identified about 77% of the patients who went on the app had ED. I think 80% actually had premature ejaculation. The other thing that's really useful is this is useful epidemiology data for patients, so that when we see them in clinic, we can say to them, you know, premature ejaculation and ED is common. You're not alone. We know this, but patients don't always identify with this. So I thought it was quite a nice little study that was presented there. There was a retrospective review from the UCL group on hematospermia. This is something that we see not infrequently, and I recall revising for FRCS not too long ago, and it was one of those vague things that there's no real guidelines, there's no real guidance as to what you should do for these patients, and everyone gives you slightly different advice about what you should do. And I think our general impression is that it's not something to worry about as long as they don't have hematuria. But what do you tell these patients? Because they're concerned. And so this was a nice study to, one, tell us the diagnostic yield, because these patients are often worried about prostate cancer. The diagnostic yield for the pickup rate for prostate cancer for this study was 3%. So you can reassure the patients that, you know, the likelihood that you've got any cancer or anything significant is low. If you do feel that this is a patient that you want to do some investigations on, there's really no benefit from doing anything except a TRUS or a multiparametric MRI. So that's really what you should be doing. They looked at a few other investigative modalities, and the diagnostic yields were very low for those. So those are the only two investigations that are worth doing if you're going to do anything. Male subfertility, there was a great talk from Pippa Sangster from UCL. We know that there's an increasing demand among male cancer patients that they want to have, they want to preserve their fertility, and we need to empower them to enable them to do that. And that means that we identify them early, and we try and cryopreserve them before we touch them with any type of treatment. We know that patients with testicular cancer often will have impaired semen parameters before they've had any treatment. That's surgery, and certainly we should be doing it before they start any chemotherapy. The best time to pick them up is before you do the orchidectomy, and that's still not standardized across the country. Urologists are still sometimes saying, well, we'll do it before they have their chemotherapy. You may have lost the opportunity to save any sperm for these men, and that's not acceptable. So what PIPA's really trying to advocate is we need to, we're not doing too badly with testicular cancer. I know I've just criticised everybody, but we're not doing too badly with testicular cancer when you compare it to the other cancers that are out there. So we need to make links with our hematological colleagues and our oncology colleagues, and that's leukemias, lymphomas, really the colorectal cancers. And while I'm on the topic of colorectal cancer, we really need to be speaking to the colorectal surgeons about inflammatory bowel disease. These are young men who will not have any advice given to them about preserving their fertility. They're going to have lots of surgery, and they're going to have ejaculatory dysfunction. So we need to make those links within our units. Now, there's some very promising results from animal studies where they've used spermatogonia stem cells, and they've had successful live birth. So there's really there's a lot that's promising for young men in the future, that we may be able to use stem cells to preserve their fertility and to help them have live births in the future. So that's something to come. I've only got one study in this section, which I think Nick Watkins is going to go into a bit more details. I thought it was a great study, really well planned, really useful, with some very interesting results. So I'm not going to say too much about it. I'm going to skip through that fairly quickly. Now, this is really my baby, and that's penile cancer. We don't have a huge amount of studies in penile cancer. We've only got one international trial, and that's the IMPACT study, which has really struggled to recruit. It's a study that we need, but it's not recruiting. We're not really quite sure why. It's an American-based study, which Nick Watkins is lead for in the UK and in Europe. But that's something that I think we need a UK study, and we certainly need a European study, and we certainly need to try and get IMPACT off the ground in some way. This was an interesting study from the Christie, where they looked at PIN and LS status with regards to P16, which is a surrogate marker for HPV status. With a retrospective study over 10 years, they found that patients with lichen sclerosus were much more likely to recur with their PIN much more quickly than those who did not have LS. And patients responded better if they had either imiquimod or imiquimod with surgery. Now, what was really interesting is 13.6% of these patients are still going to progress to invasive cancer, regardless of what their P16 status is. And this is a dilemma, because when do you discharge these patients? I'm often asked from my colleagues in the West Midlands, do you want to see these patients? My answer is always yes. I follow them up. But when should I stop following them up? And I don't think that's something that we've defined. When you look at P16, it's a strange marker, because when this group looked at progression, there was a slightly better progression rate if they did not have if they were P16 than if they were not. Whereas PIN disease-specific survival was certainly better if they were P16 positive. So I think this is an area we still need to do a bit more work on in terms of PIN and how important it is and how we ought to be following these patients up. This was a nice study from I think predominantly Nick Watkins' group, but it was a retrospective study, two super-regional penile cancer centres, Leeds, George's, Marsden and Brighton. They looked at patients over between 2003 and 2017, so good period of time, and they looked at patients who had N3 status disease. These are patients with very poor prognosis. They do not do well, and we're really looking for the best way to treat them. There was a meta-analysis late last year, which came out looking at the role of radiotherapy for high-risk pelvic nodes. And traditionally what the EAU guidelines recommended was that patients who have suspicious pelvic nodes or high-risk potential pelvic disease, so these are patients with 2 or more nodes positive from their groin node dissection, or they've got extracapsular disease. What do you do about their pelvis? And the EAU guidelines were always of the mind that we ought to be giving these patients the option of either radiotherapy or surgery to remove these nodes or treat the nodes. Now, based on the meta-analysis, the guidelines have changed last year, and they're now recommending that we ought to just give them surgery, that there's no role for radiotherapy. This is still controversial because a lot of the studies that guidelines were based on are old radiotherapy studies. So I really think this is an area that we need modern data on, and I'd urge all my colleagues in penile cancer to please let us work together so that we can actually find the answers. But back to this study for N3 disease, which is a different disease in its entirety. 82% of patients were able to complete treatment. Of that proportion, only 43% relapsed. 50% relapsed within the area that was irradiated. Now, the median survival is not great. We're not like prostate cancer and some of the other cancers in urology. Cancer-specific survival, 4 months. Recurrence-free survival, 35 months, and overall survival, 39 months. So this is a group that do badly, and we need better treatment modalities. Now, when they looked at the radiotherapy versus the non-radiotherapy groups, the patients who had radiotherapy did slightly better across all 3 areas, so overall survival, recurrence-free survival, and cancer-specific survival at 5 years. Not a lot of patients are getting to 5 years who have N3 penile cancer. So this is another nice study from the Christie where they've looked at Senti-Pen as an alternative to classical DSNB, which most of us use in penile cancer. Now, the Senti-Pen does not use nuclear medicine. It uses magnetic technology. You can inject the isotope up to 7 days before you're planning to do your procedure, as opposed to DSNB, where it's usually the day before or on the day. So it gives you much more flexibility. They also suggest that there's a reduced cost associated with it. So this is a potential area for the future that we can look at. They had very promising results which show that it was just as good as DSNB. So I think this is something that it would be nice to see this rolled out across the country. Again, I think we need to collaborate with the other penile cancer centres. My personal best of Baus this year, I was very, very pleased to see Rue McDonough get the St. Peter's Medal. He's been my mentor for years, great guy, very well deserved. I saw a talk by Ari Parnham from the Christie, which is another nice talk about updates in penile cancer. I think we all need to think about reconstruction for these penile cancer patients. They're getting younger, unfortunately. They're still presenting late, so we're still having to take off a lot of their penis. And these patients are burdened with psychological distress from this. And phallic reconstruction at UCL or one of the other centres should be part of our management strategy, and we should be talking about it with the patients early. The outcomes from these procedures are excellent, and patients should be offered in much the same way women with breast cancer are offered breast reconstruction. Ari gave another talk about career options in andrology, which was great. It's really nice. I saw it on Twitter. Still an exciting subspecialty option for trainees. We still want them to come and join the specialty. There's still lots of room. There's still lots and lots of work to be done, especially in penile cancer, I would say. And that is me done. Thank you. Any questions? And I look forward to seeing you in Birmingham next year.
Okay, so an exciting time in andrology. I think the thoughts of cryopreservation for radical surgery for testis cancer is really important, isn't it? You've brought up the fact that we need to be involving other allied specialties, so colorectal, hematological colleagues that are involved in leukemia, lymphoma. How do you think we could go about that?
That's a difficult question. I think we have to go and talk to them because these are things that are not on their radar, but they know that. I think when I was in London, I went and spoke to colorectal surgeons, and they said, "Great, we know that this is something we need to do. We just don't know how to go about it." So I think going to their MDT as a start. I think we just need to be more involved. I think they will bite our hands off. Yeah, and that's something that we have to do.
Education and collaboration, getting them coming to the testis MDT. So I do apologise, the questions coming up on the app are a little bit delayed, but we do have one now.
So we've had a great question through on the app. So should BAUS get involved in the campaign for male HPV vaccination with regards to penile cancer?
Absolutely. The government last year has actually said that boys will be allowed to have the vaccine. So I don't think we need to get involved anymore. But if they hadn't moved on that, then absolutely. I never really understood why you would just give it to boys, and we're hoping that we'll see a similar decline in the prevalence of penile cancer that we've seen in cervical cancer, but it's going to take some time, obviously, because unlike other cancers, penile cancer is going up.
Okay, thank you very much. If there's nobody else in it, that's it. Thank you. Okay, hello again. In my tearing hurry to talk about Il Divo concert, so I didn't introduce myself. I'm the chair, and I'm Suzanne Beers. I'm a consultant at Adam Brooks Hospital in Cambridge, and my specialty is female urology, voiding dysfunction and reconstruction. And just to kind of maybe feedback to Krishna, we think we're taking over the world, and we definitely haven't got the gynecologists taking over from us. I'm sorry, you're going to start a war. Okay, so my job is looking at the female and functional aspects of the last year. And what's new, and what's going to influence urological practice in the UK, what's important to everybody. And I'm going to start with the highlights. So we do have a bit of crossover with voiding dysfunction. Urolift seems to be one of the more popular and increasing in popularity, minimally invasive prostate bladder outflow procedures. And Neil Barber's group in Frimley have started a new technique called the 4D technique. So rather than pinning your implants anteriorly or superiorly to provide an anterior channel, they've put 4 implants in a configuration shown at the top of the slide on the left to open up the bladder neck. So the results in the first 50 men are comparable to other studies. So the LIFT study is the standard study, and they looked at results at 3 months. So it's the results are good. People benefit from Urolift. It's never going to be as good as maybe the more invasive treatments like TURP and HOLEP. But there was a 54% reduction in IPSS score, and as always, no reported worsening of erectile function or ejaculatory problems. However, men may be getting 4 implants where only 2 are needed. So the value of this study is probably still to be decided. Mark Rochester's group, so he's working in Norfolk and Norwich, are involved in the PULSAR study, 4 units recruiting in the UK, and they reported on the first 30 males, prostate volumes up to 100 units, and this is specifically for men that have failed a trial without catheter after alpha blocker treatment. And the results, again, they compare their it's very short term, but their 6-week follow-up compared to the standard study, which is the LIFT study, which was at 3 months. And they show improvements again in IPSS score, in quality of life, and other parameters such as flow rate and residuals. However, it's very short term. I think the interesting thing is that 60% were initially without catheters at their first trial without catheter, and by 1 month, 70% were catheter-free. So it's an interesting study. This is a very neat study from Glasgow, and it won the Best Poster Award. Over 2,700 women were looked at who have been specifically getting a flexible cystoscopy for proven bacterial recurrent urinary tract infections. And this is over a 20-year period, so a lot of work went into this, and the group should be commended. And in fact, only 8% of women had an abnormality on cystoscopy, and even fewer on ultrasound and or CT, about 0.7%. And overall, only 0.2%, a tiny proportion of women, had an abnormality on ultrasound and cystoscopy, and a lot of those were stone-related. I think the criticism that I would give to this study is that it found 195 urethral stenosis. And I know from my experience that patients being referred to me with a urethral stenosis on flexible cystoscopy don't always have them, and it's a functional diagnosis, really, not an anatomical one as such. But the important point is that only 4 patients out of those over 2,700 women had bladder cancer, and they're all over the age of 65. So I agree with the recommendation that cystoscopy should not be recommended routinely for an uncomplicated woman with recurrent UTI in the absence of any red flag symptoms or problems. And I think also they could extend that to saying ultrasound of the urinary tract as well. And then this is the study from the UCLH group looking at quite an important aspect of whether we should be giving Botox to patients that have got bladder dysfunction secondary to radiotherapy. They gathered data over 11 years from 35 patients, male and female, who had had a range of pelvic therapy for lots of different reasons. And in essence, the outcome was if this patient has got urodynamically poorly compliant bladder, so if it's a stiff little bladder, it's not going to do well, and success rates from Botox are only 30%. So we need to bear that in mind when we're thinking about this as a therapeutic option. I'm going to go on to the highlights worldwide, and I think the impact that we've had in the world of female and reconstruction has been the new guidelines that have come out from NICE, EAU and AUA, and I'm going to look at which elements of our practices for everybody do we need to change. So in a nutshell, NICE guidance was published on the 2nd of April, and it tells us that urodynamics are not needed for pure stress urinary incontinence. We knew that from before, but they've extended it to include stress-predominant mixed urinary incontinence as well. And this has a huge cost saving. Urodynamics are about £250 per person, roughly. That's data from a couple of years ago. About 8,000 women in 2017 were having stress urinary incontinence surgery. If over 90% of those were getting urodynamics, it would cost us £1.8 million. So there are cost implications to this guideline as well. Anticholinergics, importantly, we're not now told dictatum what we need to give, but we give the drug of lowest acquisition cost. We've got to consider the anticholinergic burden and look at the other drugs that patients are on, and we're now obliged to counsel those patients on the potential risks of cognitive impairment. GPs are going to have more work to do. Anybody on a long-term anticholinergic will need to be monitored every 12 months and every 6 months if they're over the age of 75. Looking at overactive bladder and Botox, NICE guidance have now said that you don't have to have urodynamic proven detrusor overactivity in order to give Botox, and we're going to start with the licensed dose now in idiopathic overactivity in women, which is 100 units. But you can go up to 200 units if that patient hasn't had the correct efficacy from that, i.e. the effects haven't worked or it hasn't worked for long enough, not for 6 months. They're encouraging the role of the local MDTs. We had this from the last guideline, but there's more flexibility now. People were finding it difficult to maybe gather the right complement of people, so it can be 2 urologists or 2 gynecologists or a mix of both, with other specialties including continence nurse specialists and physiotherapists. And then a bigger change is the role of the regional pelvic floor MDT. So this is designed to have a much more comprehensive number of specialties involved, so urogynecology, urology, colorectal, pain services, etc. And it's probably going to be for the mesh and the complex cases. And this is going to go hand in hand with the new specialist commissioning of mesh centres in the UK, which is ongoing. So looking at stress urinary incontinence, I think for urology this has been fairly controversial. And the recommendations of NICE are that we can offer Culpa suspension, autologous fascial sling, and retropubic synthetic midurethral tapes. Now, they did a huge network meta-analysis and systematic review. It's 759 pages long. And it had 141 articles and 109 randomized controlled trials. And in essence, overall, the thing that came out top was actually the midurethral sling. Doesn't mean we can use it at the moment, and I'll talk about that. And they felt we could consider bulking agents as the evidence from the randomized, there was only really one randomized controlled trial that was considered. The evidence was weak, although there are new trials coming out looking at products like Bulkamid against TVT, and the outcomes are reasonable. But the other important thing to emphasize is that you should, if you're counseling somebody on stress urinary incontinence, you should talk about all options, and you should be using a patient decision aid, and you should be documenting that you've given that to the patient. The NICE one on stress urinary incontinence surgery is quite limited. It's only really looking at primary stress urinary incontinence surgery, and it's about 16 pages long. BAUS have an excellent one that you can adapt for primary and recurrent stress urinary incontinence, and it includes everything, including artificial sphincter. So in looking at this and making their decision about what's in and what's out with stress urinary incontinence, they did look at the ESTER study, which again is a gigantic study. It's over 300 pages long. It was 175 randomized controlled trials, over 21,000 women involved, and they compared all the different, or 9 different types of surgery to each other for stress incontinence. And again, their outcome essentially was that retropubic tape is going to be the most effective and the most cost-effective over the lifetime of that patient, closely followed by autologous or traditional slings and Culpa suspension. If you look at the complications from the same group, it's interesting to note that complications of chronic pain were about the same for retropubic and transobturator tapes, about 5%, and the risk of erosion or extrusion was 1 to 2% in both categories as well. NICE haven't completely said we can't do transobturator tape as a route, however, it needs to be reserved for specific patients. So how do we compare? How does NICE compare to the new European Association of Urology guidelines on incontinence? They're very similar. So be careful of antimuscarinics in the elderly. You can offer a midurethral tape in Europe still. That transobturator and retropubic routes are equivocal at 5 years, but retropubic just pips it to the post at 8 years with higher objective success rates. Warn patients about pain, and particularly in the transobturator group, the risk of groin pain. And bulking can be offered, but counsel that patient carefully. Yes, it's a low-risk, minimally invasive treatment, but repeat injections may be needed, and long-term efficacy and durability are not clear and not known. So carrying on with the rules that are laid down really by NICE, by NHS England, NHS Improvement, and from the Independent Medicines and Medical Devices Safety Review, which is led by Baroness Cumberledge. And the take-home message from this is if you're going to put anything synthetic into a patient, whether that's mesh, whether that's a non-absorbable suture for your Culpa suspension, whether it's bulking agent, you have to let that patient know what product you're doing. It has to be detailed. You have to have the unique product identification code documented. You have to document anything about any investigation or treatment of any complications, and women need to be given a copy of their own data. And ultimately, for us to be able to practice freely and different treatments in the future, we need a national registry of stress urinary incontinence surgery and a database with a link to the MHRA. And we need specialist mesh centres, which are being currently looked at by the commissioners. And yes, we do have a BAUS a database through Dendrite, and yes, that is ongoing, but it doesn't fit the criteria. They want 5 years follow-up, and we need to work with BSAG and the government to try and produce a better registry. So the current situation is that there was a high vigilance call-out on mesh in July last year, and in March this year, literally 3 days before the NICE guidance came out saying that synthetic mesh could be used for incontinence, there's been an extension to the pause of vaginal mesh use, and we cannot use mesh for either incontinence or any kind of vaginal prolapse surgery at this current time. So going on, one of the things that NICE missed out was mirabegron. It wasn't in the questions that they were looking at, and I think there have been great advances. And if we're thinking about anticholinergic burden and we're worried about using anticholinergics in the older population, then mirabegron kind of is where we're looking. And so the trials that have come out that are helpful for this most recently is the Synergy trial. This trial looked at, well, eventually they did an analysis on 1,700 patients with wet, so incontinent, urgent urinary incontinence and overactive bladder. And it was either monotherapy with mirabegron, monotherapy with solifenacin 5 milligrams, or a combination of treatment. And across the board, they all did well. They all had benefit from it, but the most benefit was from combination therapy compared to monotherapy. And then looking at the older patients, so yes, it's a reasonable drug to use, they both are, but what about this older population that we're trying to protect from cognitive impairment and other problems? And they've broken everything down into younger than 65, above 65, and above 75. There were treatment-related adverse effects in up to 50%, but these were quite minor, and predominantly the ones that were discussed were dry mouth and nasal congestion. It was actually the younger patients that had a rise in their pulse rates with mirabegron by about 1 beat per minute, but not the older patients. Side effects were slightly higher in the older patient groups. Overall, the greatest efficacy was generally seen with a combination therapy treatment. However, in those under 65 regarding urgent incontinence, solifenacin did quite well, and in those over 75, frequency of urinations, but again, solifenacin versus combination therapy was quite similar. So recurrent urinary tract infections come up again. They're a big part of my practice and of my colleagues' practice, and the AUA guidelines have come out this year as well. I don't think there's anything groundbreaking, but it's a sensible, pragmatic kind of guide to look at. It explains that we should be doing a pelvic exam in all women with recurrent urinary tract infections. We should not be performing ultrasound or cystoscopy, so that fits quite neatly with our abstract that we discussed earlier. And we shouldn't be treating asymptomatic bacteria in the non-pregnant patient. When they talk about antibiotic treatments, obviously fluoroquinolines are out the door at the moment due to the risk and the safety issues and tendinitis. So America's now gone to using nitrofurantoin, Septrin, and fosfomycin. Not necessarily what we're going to do in the UK. But if you're going to give treatment course of antibiotics, give it for the shortest duration possible and no longer than 7 days. And when they talk about prophylaxis, they say, yes, you can give it, but no longer than 12 months. And in the perimenopausal and postmenopausal women without risk factor, think about topical estrogen therapy. Interestingly, they advocate cranberry, and interestingly, they didn't think they had enough evidence on things like methanamine and D-mannose and intravesical therapies. But I think what's going to be important in the next year, maybe, or two, is the results of the ALTAR study looking at the role of prophylactic antibiotics versus methanamine for recurrent UTIs in women, and hopefully those results may be available for next year. So the ANTIC study looked at recurrent urinary tract infections in patients performing intermittent self-catheterization. Again, a lot of patients in my particular practice have got this problem. So in people that do CISC, they've got about a 25% risk of recurrent UTI. And miraculously, if we give them prophylactic antibiotics as they did in the ANTIC study, that risk can be reduced by 48%, but it comes at a huge cost. So you're between a rock and a hard place. We have desperate people having horrible infections. If we give them prophylaxis, their risk of antibiotic resistance doubles. And in fact, with Septrin, it almost tripled. So it's just something to be careful of, and I think it's for selected patients. And then finally, in the world of overactivity, we've had the Rosetta trial. It published at 6 months, and now the results are out at 2 years. And it's comparing 200 units of botulinum toxin in the bladder compared to sacral nerve stimulation. And ultimately, at 2 years, they work equally. They do equally well in reducing the episodes of urgent urinary incontinence and resolving urgent urinary incontinence, and cure was about 5% in each group. Overall, patient satisfaction was better in the Botox group, but equally in the Botox group, there was a more than double increase in the risk of infection. And over the 2-year period, 24% had to perform ISC, although that may be temporary, and it was about 6% after the second Botox injection. And revision and removal rates for sacral nerve modulation were actually reasonable and quite low. So in summary, I think if you're going to go away and look at anything in this field that would be helpful to you, the NICE guidelines are essential. The EAU guidelines are really informative and helpful, and they also look at male incontinence as well, which is very useful. AUA guidelines on UTI don't kind of break any new boundaries, but are good that they're written down. And then we've got the other papers evidencing prophylactic antibiotics with catheterization, Mirabegron combination therapy, and SNS versus Botox, and they're both working out quite well. All right, thank you, and I'll take questions. Everybody's so shy and it's so dark, I can't pick anybody out.
So, Suzanne, I've got some questions for you. What are your thoughts, or is there any evidence in the last year on vaccines for recurrent UTIs? Anything new? Any nuggets of information for us?
So I've seen Chris Harding in the audience, and I'm going to get him to answer that for me, because he is the guru of that. He gave the most amazing talk I've ever heard. So at the moment, I don't use a vaccine. There's the Eurovax, which is an E. coli type vaccine, which is available, I think, in the private sector, but it's not something I have available to my patients. And my understanding is that is helpful. Chris, please enlighten the audience.
So in terms of vaccines, the most exciting development in the last 12 months has been with a product called Euromune, which is a sublingual preparation which is taken up by the lymphatic system. And being sublingual, it goes with distributions for both oral and nasal, so it gets really widely distributed. And up to now, they've only had pilot data from Spain, but they are actually setting up an RCT, which is going to be multi-centre and in both the UK and Spain. So I think that's probably the most exciting research development in the last 12 months. The other vaccines have varying evidence to support their use, but I agree Eurovax was probably the one with the most promise, but there's been nothing published this year, just a lot of trials in setup.
Thanks, Chris.
Thanks, Chris. And so I've got another question that come through on the app, and there's trying to sort of coalesce a few questions together about the role of urodynamics. And so with Botox, the license for Botox is for wet OAB, and NICE are now suggesting that there's no need to do urodynamic studies. So where do you think we stand with urodynamics, Botox, and dry OAB?
In my trust, I'm able to give it if anybody's got overactive bladder symptoms. So now I'll see them, I'll assess them, and if I feel they fit that category, and I don't think there's anything else that I need to exclude with urodynamics, I'll go ahead and do it. I think it's something I'm allowed to do, and I think many people in their practice also do it for dry OAB.
Can I just ask a related question, Suzanne, and possibly to Chris? With stress urinary incontinence and role of urodynamics, given the mesh controversy, the publicity, it is attracted, in UK urology, stress urinary incontinence, is that getting more urodynamics before treatment or less as per NICE guidance?
I think the sad fact at the moment is women aren't coming forward for surgery or coming forward for treatment. So we found that across the board, we would have imagined maybe that if tapes aren't available, there'd be an increase in things like Culper suspension, autologous slings, but the uptake of everything is on a downward trend. Are we more careful about things? I think you have to take everybody individually, and it still stands that if you're unsure about the exact type of their incontinence, or if they're urge-predominant urinary incontinence, mixed urinary incontinence, if they've got prolapse, if they've got any avoiding dysfunction or anything else, you should do urodynamics still. And if you had any concerns, you judge it on an individual basis and do it as it's needed. But I understand from the evidence about doing urodynamics was based on 4 randomized controlled trials. It is a bit limited. The grade of evidence was low to moderate, but I think you just have to make a judgment.
So on the theme of mesh surgery, a great question. Will we ever do mesh surgery for stress urinary incontinence again?
Yeah, that's the question, isn't it? So Baroness Cumberledge, the patient groups have had a lot of momentum with what's going on it's interesting, isn't it? The evidence base that it's reasonable to give, and yes, chronic pain is there, and we have to counsel patients really, really carefully about pros and cons and make sure the option's there. I don't know whether it's going to come back. There's even a question mark over male sling mesh procedures, so the male advanced system. We have, so NICE guidance is that we should be putting mesh in males for incontinence within a research study, and unfortunately the master study has closed and Paul Abrams is about to present on it. And so individual trusts have to get permission from their medical directors to offer that to men still. So will it come back? I really don't know at this point in time.
So a final question just to finish up with. There's a question come through on the app about the role of long-term antibiotics as prophylaxis for urinary infections. And there are groups of patients around the country who've been on those for years and years and years. Should we be turning around and denying those patients the treatment because they've had it for 12 months now, as per the American suggestion, or do we just let them carry on because it works for them?
I think they need to be reassessed, re-examined, rechecked, see if there's alternatives. If they're on nitrofurantoin, they need to be getting liver function tests and lung function tests every 6 months. I would normally not put somebody on nitrofurantoin long term. Again, it's challenging, isn't it? Because the people that are on the low-dose antibiotics for a long time are absolutely desperate, and you're absolutely desperate, and you'll have tried everything. So again, it's on an individual case-by-case basis. But ideally, they should at least be stopped and assessed at 12 months, I would think. Okay, I'm going to stop there. I'm going to thank the speakers for the highlight session, give them a round of applause, and I'd like to ask our breaking news session speakers to come up to the podiums, please. I curtailed the female section is because we've put in breaking news from some of the most excellent kind of functional studies that are reporting at the moment, functional and reconstructive studies. So this really carries on from my session. And we're going to get breaking news on 4 excellent studies from 4 excellent professors. And apparently a group of professors is an entrenchment of professors. Have you ever heard that, Paul? No.
Thank you, Suzanne.
It's all right, you're welcome. So I want to introduce Paul Abrams, he's at Southmead Hospital, Professor of Urology at the University of Bristol. Thank you, Paul.
Thanks. Well, just to remind you, the master study was designed to establish whether the male sling or the artificial sphincter gives better outcomes, obviously by randomization, and the aim was to randomize 360 men. The primary outcome was judged on whether the patient said they leaked and how much they leaked. If they answered positively to either of them, then obviously they were not dry. And then secondly, at 24 months was the cost effectiveness between the sling and the sphincter. So the study outline originally intended that we would look at 360 men, and there was a non-randomized cohort which was closed. I think I'll just show you the consort diagram, which is a stunning success for British urology. And the 27 centres, having been told internationally that we would not be able to do this study, recruited above the 360 and in fact recruited 380 men. And their 12-month follow-up was completed this last 31st of December, and the 24-month, that is the cost economic analysis, will be completed this December the 31st. Again, we work with Aberdeen, and they produce this wonderful ratio of returns. So this is extremely high in a randomized controlled trial. These are the returns of the questionnaires. So we have very good data. Now, This is the disappointing bit, because we had expected to be able to give you results, and we have a lot of results, and this is the problem. There's a huge amount of data. So I'm not able to say anything today about the results, and I apologize for that. It's frustrating for Aberdeen, for us, and of course for the PIs. The primary outcome is the incidence of leakage, but we have this huge amount of secondary data, and the time is taken in looking at the secondary data. We want to obviously have an excellent first publication, given this for British urology is a big event. I just remind you that the only existing RCT is 45 patients comparing sling with an injectable. So we have 380 patients. So this is going to the New England Journal of Medicine. And they are quite emphatic, as is the Lancet and the BMJ, that you must not give the results out in a public forum. And this is regarded as a public forum. So whilst we had planned to submit by this date, we haven't, but we plan to submit within the next month. And then we will obviously put these results into the public domain. So I'd just like to finish, as I say, by thanking British Urology, all the PIs, Aberdeen, all the research nurses. And this is a picture, of course, of Rob Pickard, who we all miss dearly, and he was extremely important in the setting up of MASTER and made a huge contribution. And we, of course, still miss him very much. So again, I apologize for not giving you results, but thank you for listening.
So our speakers are all going to give you a little snapshot, and then we'll have an open forum discussion at the end, if that's okay. So I'd like to invite now, I've got to get my right bit of paper, Professor Marcus Drake. We've got the right one, got the right professor this time. He's going to be reporting upstream study, and Marcus is a consultant at Southmead Hospital in Bristol and a professor of physiological urology and a senior lecturer at the University of Bristol.
Senior lecturer's a bit out of date.
Is it?
Yeah.
You've got to update your biography.
Sorry. So thank you very much indeed, and thank you for those resilient people staying on towards the end of BAUS. Please note my disclosures. I've highlighted in red the funding of upstream, and that includes the secondary grant which will fund the 5-year extension study, and that will be starting shortly. The point about this study is to look at whether urodynamics would reduce surgery in male LUTs, basically thinking that if somebody's got detrusor underactivity, then it's rather pointless to think about surgery to relieve bladder outlet obstruction. So the aim is to see whether we'd reduce surgery rates without impairing symptom outcomes. And there was a couple of additional aspects. Could we actually identify facets that would bring a bad outcome risk? And how well are the tests done? We've already got 4 publications out in public domain, and they are listed there. So the basic structure, when a man is referred for LUTS treatment, he is randomized. He will have a full assessment with urodynamics, as indicated on the left side, and he would then proceed to treatment of his choice. Alternatively, he'd be randomized to that full assessment, but without urodynamics, and again, he would choose his treatment. And the key secondary outcome is amount of surgery done in the 2 arms. The primary outcome measure is urinary symptoms as measured by IPSS. So the inclusion criteria were straightforward, referred with LUTs, thinking about more treatment, exclusions, catheters, neurological disease, cancer, and rather obvious exclusion criteria. So this consort diagram almost matches MASTER as a triumphant example of British research prowess. Main outcome. We were able to confirm non-inferiority in the urodynamic arm. In other words, equivalent symptom outcome. Overall, symptoms dropped from 19 to 13 in the study overall, including both treatment arms. Surgery rate not reduced by urodynamic evaluation for various reasons, but we did not find a reduction in surgery rate. What about the bad outcomes, though? Now, this is one aspect that actually is quite troubling, because when we looked at the overall change in symptom score, you can see indicated by the red arrows where people had, in effect, no change in symptom. And you can see that there are people who got worse, including following surgery, which frankly is a very bad situation. So some of the aspects, now this is ongoing, because like Master, there's a huge amount of data. But one thing is that if their quality of life score on the IPSS is 1 or 2, do not do surgery. Furthermore, you need to categorize what LUTs are present, because if it is post-micturition dribble, storage like urgency, incontinence, or nocturia, do not expect them to improve with surgery. And this habit of asking somebody if they've got a slow stream and believing that justifies proceeding to surgery, that is incorrect. You must only proceed to surgery if the voiding LUTs are bothersome, not the other LUTs. And one thing that we would criticize, there was quite a large number of sites where really the equipment was not used correctly in terms of maintenance, calibration, and checks. And this is quite serious. We also need to be very careful when we're interpreting the reports coming from these basic assessments. We've got to check them, we've got to exclude fundamental errors. And there were examples like this one, a bladder outlet obstruction index being given, yet the vesical catheter had fallen out before maximum flow rate. Clearly, it is not possible in that situation to get the bladder outlet obstruction index. So the key message is, urodynamics is not a test for routine use prior to prostate surgery in the sense that, while symptoms are equivalent, the surgery rate is not reduced. But there is almost certainly a reason to use selectively. The treatment outcomes are modest, and at baseline there were serious issues. So the top line, we can't say that urodynamics is not needed. What we have to say is, if assessed properly, urodynamics is optional in men who are principally bothered by voiding LUTs. And there is listed the main assessments, and we've got to be really getting our act together when it comes to service provision here. And these are the acknowledgements. Thank you so much.
Thank you. Chris, I think we're going to have to change the name of our section from the FNUU at this rate. Urodynamics not faring very well at the moment. So I'd like to introduce Professor Hashim, who's going to talk to us about the UNBLOCK study. And Hash is also a consultant at Southmead Hospital, Bristol. They're breeding some good quality doctors there nowadays, aren't they? And an honorary professor of urology and director of the urodynamics unit. I'm just going to talk about Thuvarp, which really sounds like a Klingon leader in Star Trek or something, so you need to educate me. Thank you.
Thank you very much, Suzanne, and good afternoon, ladies and gentlemen. So I'm going to talk about Thuvarp versus TURP and the UNBLOCK trial. And basically, this was an HTA-funded trial which came about after a surgical-themed call for surgical trials. So we actually had to compete against other surgical trials where they chose 10 out of about 30 applicants. So we did quite well to get this one through. And where it came about is that benign prostatic obstruction is very common. TURP is the commonest procedure that is performed in the UK. And holmium laser, according to NICE guidelines, should only be done in specialized centers who have high volumes, and it's not for everyone. So we thought then, well, how do we go about and using laser in a situation where it's similar to TURP? And looking at the literature, so Thuvarp is thulium vapor resection of the prostate. So it's using thulium laser, which is a continuous laser as opposed to an intermittent one, which holmium is. And it's vapor resection, so it vaporizes and resects the tissue. So it's effectively what you're doing is actually resecting similar, hand motion is similar to a TURP motion in terms of operatively. And there, looked at the literature, there was only one Chinese trial looking at the TUVARP versus TURP. So we decided to use TUVARP. I got trained on it, and then we decided then to run the trial, and we got successful. It was basically looking at TUVARP versus TURP. This is TURP, it's both bipolar and monopolar, so standard practice. It's men with voiding LUTs and retention, and this is a unique trial in that usually retention patients are not included in the BPO trials. And it was a very pragmatic trial, so anyone who's eligible for a TURP would be eligible for the trial. And the primary outcomes were the IPSS again and the maximum flow rate. And secondary outcomes looked at complications, healthcare costs, and symptoms. So we had 7 centers mixed between DGH hospitals and teaching hospitals, and you can see the hospitals there. So we covered both Scotland and England, and Aberdeen, Newcastle, Leeds, Cheltenham, Swindon, Bristol, and Truro. So we had 475 men, which is very good, and this was a randomized, essentially blinded study. So the patients were randomized at the point after they were anesthetized. So neither the surgeon nor the patient knew what operation they were going to get until the day of the operation for the surgeon, after the patient was anesthetized, and the patients didn't know what operation they had at all. So they were randomized between the 2 arms. We had equal allocation between the 2 arms, about 205 patients, and then 150 received the TUVARP because some crossed over at operation, and 200 received the TURP, and they completed 12 months follow-up with very good completion of questionnaires and flow rates. So the results, which were interesting. We found that the baseline obviously was similar in both groups, but in terms of outcomes, the IPSS score and for both TUVARP and TURP were similar. However, TURP was superior to TUVARP in terms of improving flow rate. So the maximum flow rate with TURP was about 23, and the maximum flow rate with TUVARP was about 20. Now, from a clinical point of view, obviously, both of them are good. They've improved flow rate from a baseline of about 6 or 7 or 8 up to 20. So technically, they are both good, but in terms of sub-analysis, the TURP was superior. Secondary outcome, everything was exactly the same. The surgical complications, transfusion rates, the hospital stay, which was about 2 days, sexual symptoms, urinary symptoms. We said that 25% of the TUVARP patients had a TURP in the end. That's because of equipment failure. The TURP was slightly shorter by 20 minutes, and the TUVARP was more expensive slightly by £70, which is non-significant. So in conclusion, this is the first trial to provide level 1 evidence. It's government funded. TUVARP and TURP are equally good, but TURP is superior in terms of improving maximum flow rate, and length of stay certainly is shorter than what it is in Asia. It's about 2 days, but both procedures are good. Thank you very much.
Okay, and then finally I'd like to invite Professor Nick Watkin to the podium. He's going to tell us about the OPEN trial. He's a consultant urologist and professor of urology at St George's Hospital, University of London Medical School, and obviously it's the best medical school in the country. Thank you.
Thank you very much, ladies and gentlemen. And before I start, I'd like to echo what Professor Abraham said. Rob Pickard's influence is all over this trial, and obviously he was chief investigator until his illness prevented him from continuing, and I inherited the role of chief investigator towards the end. So, the OPEN trial, this was a randomized trial comparing the superiority of open urethroplasty versus endoscopic urethrotomy in patients with recurrent penobulbar urethral strictures. So our primary outcome was a subjective outcome based on a validated patient-reported questionnaire, which the trials team essentially were involved in constructing in years preceding the open trial. And the outcome was essentially the area under the curve of repeated measurements of the subjective outcome from baseline out to 2 years follow-up. The secondary outcomes were need for reintervention, relative change in flow rate, cost effectiveness, and safety profile. This again was an HTA NIHR funded trial hosted in Newcastle and supported by the trials unit in Aberdeen, and obviously supported, as you can see, by 38 trusts and principal investigators across the UK. And it's from them really this trial has been made possible. So we recruited over a 2.5-year period to reach what was originally 210 men to power the study, and we recruited 222 men across those sites. Then there was a 2-year follow-up period, so the trial closed at the end of 2017, and our data analysis was complete, and our report is being formulated as we speak. So the baseline characteristics of the two arms were very similar. There's perhaps a slightly older age group than you might have expected for urethroplasty, but they were equivalent. These are bulbous strictures, predominantly about 2 centimeters in length, flow rates around 10 mils per second, and about 1/3 of the patients had had their previous intervention more than 12 months before trial entry, and 2/3 were within 12 months of trial entry. This was a pragmatic study in which patients post-treatment were allowed to self-catheterize if they wished, but in reality, only a minority of patients chose to do that in the ureterotomy group. So this is the data that you want to see. We had 159 patients who completed sufficient questionnaires for the primary analysis, and you'll see at baseline the symptom score, which is, in this case is out of a maximum of 24, was around 14 in both groups, and immediately fell in both groups to a low point of just over 4, and then very slowly rose to the end of the trial time follow-up to around 7 out of 24 in both groups, with no significant difference between them. In terms of secondary outcomes, the strength of the stream in the two groups followed exactly the same pattern as the symptom score. The global quality of life question, again, was similar for both groups, pretty much following the symptom score. And surprisingly to us at least, the flow rates at 2 years were equivalent in both arms of the study. For other secondary outcomes, the need for reintervention was different, and significantly so. 16% of the urethroplasty patients had a reintervention, and 28% of the ureterotomy group had a reintervention. And the time to reintervention in the ureterotomy group was shorter significantly than the urethroplasty group. So in conclusion, we now have level 1 evidence for the relative benefits of both urethroplasty and ureterotomy in penobulbar strictures, with a follow-up out to 2 years. We also have the equivalence of the two types of procedure out to 2 years. We can also say that the flow rates that you'll experience at 2 years are also both very good and equivalent. But we can, if you're a urethroplasty surgeon, say that you'll have a slightly better outcome in terms of reintervention in that group than in the ureterotomy group. Thank you very much.
Thank you very much. I'd like to thank all the speakers. That was an excellent snapshot they've done, and I'd like to thank them for keeping to time as well, because it's quite a hard job to put years and years of research and study into just 5 minutes. I'd like to open the floor to questions to all of the speakers, please, now.
Wow.
Can I ask Marcus a question?
Yes.
Is the IPSS symptom score now a defunct assessment tool?
Yes. So what we've done is an analysis to look at symptoms that really matter to patients, and post-micturition dribble is startlingly important to patients and is not even mentioned in IPSS and is clearly going to be relevant in your area too. And also incontinence, well, what a surprise, that really matters to men and it's not captured in IPSS. So we've looked at the ICIQ and we've got the full range of symptoms clearly captured by that, and we now, thanks to Upstream, and we'll probably do the same with unblocks as well, got the minimally clinically important differences for ICIQ. So we've got what we need now to make this the state-of-the-art assessment.
We've got a speaker, a question on podium, well, number
Tim
one.
O'Brien, it's a question for Marcus. Marcus, I'm not a trials methodologist and I'm not a functional urologist, but why isn't urodynamics dead in the water after your study? It doesn't provide any benefit. Why isn't it just dead in the water?
The issue here was to decide whether detrusor underactivity is a key driver when it comes to surgery rates, and that wasn't demonstrated. So in that specific context, it's not bringing anything useful. But there's a whole range of issues that actually bring men to the clinic, and they can be informed by urodynamic evaluation. But most fundamentally, it's the full pathway of assessment that has to be done properly, including the symptom score, the bladder diary, sexual function assessment, and flow rate testing. If those are all done properly and interpreted appropriately, you may well find that you've got the key information and urodynamics may not then be necessary. But they're generally actually not done that well. And unless they're routinely, properly incorporated, urodynamics is going to make up for a weakness in the delivery of the rest of the pathway. So it's not dead.
Okay, I think Paul's got a comment, and I think we've got a question on number 3 next, please. So, Paul.
Tim, I think the issue of quality of urodynamics is very significant, and there's a very good, apropos what you were discussing, Suzanne, with stress incontinence, there's a very good analysis of the randomized controlled trials which purport to say that urodynamics are not useful in female stress incontinence by Finazzo Agro. And having had experience of central reading with urodynamics from across the world, it's depressing. And it's not surprising because there are no quality assurance in urodynamics that occur in other areas of physiological measurement like neurophysiology, respiratory function tests. There's no proper training in urodynamics worldwide. And I think this is the explanation for the disappointing quality that Marcus found. And I think it's probably better in the UK. From our experience, it's actually better in the UK. It's worse in America and worse in Europe. So there's a huge issue here. And we shouldn't be debunking urodynamics until we've got our house in order in terms of training and technical standards.
I've got a question on 3, then 2, then 1. So 3, I'm sorry, I can't see anybody. It's very dark
My
out
question
there.
is about the urethroplasty versus optical ureterotomy. Previously, we know the results of urethroplasties have been superior. My only question is regarding the optical ureterotomy, those patients, have they had self-catheterization during the study?
Yes, they did. So it was a pragmatic study, and the numbers of patients who elected or they were encouraged to self-catheterize afterwards was actually quite small. It was about 20%. And when we looked at the data of the 20% that self-catheterized, there wasn't actually any difference in that group compared with the group that didn't. So whilst it's a weakness in an element of design, it was meant to reflect real-world practice.
Okay, number 2, please, Tamsin.
Yeah, hi. Do you think we should devise some kind of score to look at the quality of urodynamics, and then you could go back and look at your study to see if good quality urodynamics made a difference?
It would be nice. I think that'll be quite difficult to do. So instead, the way we're playing it is under the umbrella of the International Continence Society, we're bringing together the European Society of Female and Functional Urology, SUFU, and the AUA in a consensus group with a few additional experts, including representatives from BAUS, to try and get this is the situation. This is the benefit that comes from proper pathway assessment, and this will be an example of how it helps. So a consensus statement from the leading organisations, which I hope will go part way to achieving what you're alluding to, I think.
And my second question is, should we give up urethroplasty?
Oh, no, not at all.
That was nice and succinct. Mike 1.
Yeah, Marcus, there's another one for you, I'm afraid. The concern isn't about urodynamics, it's about education in urology. Why is anybody doing TURPs on people with nocturia and don't have significant flow problems? I mean, that's surely, I don't understand that.
I don't think we have a large number of people with nocturia and no flow problem. I think what we've got is a large number of people with a flow problem and nocturia, and a supposition that if you improve flow, you're going to help nocturia. And that basically is where I feel we're making the mistake, because if no proper bladder diary is done, you have no handle on the underlying mechanism of the nocturia. So any improvement is actually a fluke. And if you really interrogate the men and they're saying that the voiding LUTs are non-bothersome, you basically will have a bad outcome. But we're going to sort of bring it all together properly in the various potential combinations, including the one that you allude to, Lawrence.
But that's my concern, if there's something wrong with education as to who we're operating on, nothing to do with urodynamics.
Yeah, but I think it's relatively modest, that specific thing that you bring. But education is our intent to really make the impact from the study.
I've got a comment for Marcus. I think we need to have a complete rethink about how we're offering bladder outflow obstruction from the upstream study. If you had a man that had overactive bladder symptoms, you did urodynamics and he had a voiding pressure of 100 centimetres of water, a flow rate of 10 mils, and he'd shown some overactivity, so he had bladder outflow obstruction and true overactivity, but wasn't bothered by his voiding symptoms, what would you do? Because we shouldn't be treating men with outflow obstruction, you know, with anticholinergics or potentially mirabegron. We can potentially cause retention. So what's the balance? How do we address that kind of patient?
Well, if you are trying to improve symptoms, then improving the flow rate when the flow rate was non-bothersome at presentation is not likely to really bring any great gratitude, and it might actually bring complications. Furthermore, you can treat with antimuscarinics or mirabegron. Most people, provided they're neurologically okay, are unlikely to go into retention. And we've got enough information there. The only exclusions that we've got in the studies where men were treated related to post-void residual, not bladder outlet obstruction. So you can use those medications, I'd say.
Okay, maybe with the caveat for them to be careful. Yeah. And we've got one on the... Oh, we've got two people. Sorry, I better stop.
Sorry, Suzanne, it's me again, Tim. Hashim, I was absolutely fascinated by your data that so many patients didn't get the treatment they were randomized to in the laser arm, which it just seems extraordinary that so many... You're randomized in an anesthetic room, and then nearly 20% of the patients didn't get the treatment they were randomized to.
Yeah.
What's going on there? Has no one worked out beforehand how the laser worked, or what was the basis for that? It seems extraordinary.
So part of it was that the laser, wasn't working when we start the trial. So when you're starting the operation, the laser didn't work, or the fiber broke down. So machines do break down. There are other reasons. So you found bladder cancer, for example. You found the urethral stricture. So there are other reasons why they didn't have the operation, the TUVARP. But the machine breaking was the main one, and that was, that's just part of the being pragmatic. Machines do break down, unfortunately.
But isn't that the sort of thing you identify before you do the randomized trial, that this is reliable technology or not? It seems extraordinary that it would have happened just in the trial.
Yeah, no, I mean, it's reliable technology, and it must happen in other places, but this is not a widely adopted, it's not practiced in the UK a lot. There's only probably 2 centers doing thulium vapor resection. It is mainly in Germany and in China. So, the machine does work, but if it breaks down, it breaks down. I mean, all laser machines break down.
Thank you.
The other comment I would say is that the inpatient stay for TURP and through VARP was 2 days. We do we do bipolar TURP as day cases, and they go home the same day with a catheter.
Yeah.
I'm just interested to know, a 2-day is...
so this, remember, it's sort of, we included both bipolar and monopolar. And so some centers, such as, we still do monopolar, and some do bipolar. And so the average worked out to be 2 days.
Okay, we've got 2 minutes left. If I can go to mic 2, if you can...
Just very quickly, Marcus, do you think the upstream results have put to bed the kind of classical teaching for the case that Suzanne highlighted, which is outlet obstruction and concurrent overactivity, where traditionally you would treat the obstruction and expect 60% of them to, the overactivity to go away?
I don't think I can actually say that from the analysis completed so far. It is one of the questions that we're going to ask. It'll be one of the questions as well for the 5-year extension study, where it's a better chance, because short term you might see some symptom improvement, but the long term change in detrusor overactivity we already know doesn't actually change after bladder outlet obstruction surgery from Alan Thomas's paper with Paul. So we already know the answer to that. It doesn't work.
I'm sorry, we've just run out of time. I'm sure the speakers will be happy to answer any other questions when they step down. Sorry to disappoint you.
Wasn't a comment, it's just to say that the collective noun for professors is an abstinence.
Abstinence, is it? Thank you. I'm educated again.
Well, thank you.
What more could I wish for? So I'd like to end the session. I'd like to thank all the speakers from the highlights, the best about, and the breaking news. I think it's been highly informative, and thank you to the audience, and well done for staying so long. Thank you.
Well done. Really good.
Okay. And I think we've...
To stay right to the end. What a meeting. I think it's been one of the best meetings for many a year, and thank you to everybody who contributed. These are some of the figures just to go home and think about and ponder before next year. We had 972 delegates this year, lots across the whole range of urological provision. 21 nations were represented. We had 15 overseas guest speakers, which as usually worked quite hard, and they contributed well. The abstract submission rate was a bit down this year. It's 24.4%. That's because we had more abstracts, the highest number of abstracts submitted since 2011. So people are putting their work into the meeting, which is great. I've got to say thank you very much to the abstract committee markers, sorters and committee, the 62 people who did that. And especially this meeting has been so good because of the work of these 4 people who've done a really outstanding job, and thank you to them. I think they deserve a round of applause, actually. Beck, as usual, has overarched all the sections to make sure there's not too much duplication. The section chairs and executive committees have been fantastic and very coordinated this year. So there's almost 100 people. It was a shame we couldn't get 100, isn't it? Almost 100 chairs for the meeting. That includes all the different sessions. Most of the courses were sold out pre-meeting, which was good, and we liaised with all these organisations. You can see there we had 73 companies exhibiting and 5 sponsors, and this meeting really couldn't go ahead without the support from the industry, so thank you very much for our industry partners. I think it's another round of applause, actually, if that's all right. Let's get your arms moving before you go home. Social media, something I don't know really much about, but apparently 3.591 million impressions. I don't know what that means, but that sounds quite good to me. 2,500 tweets, more or less. 609 active participants, which is not bad out of 972, is it? 3 tweets per hour on average. I'd like to see the stat of actually tweets after midnight. I think it's quite interesting. And tweets per participant, 4. So thanks to Veeb and Neha for putting those figures together. In terms of the app, which I think is quite good and a good development, I even managed to download that and use that, which is quite a feat in itself. 990 active downloads, which is more than the number of delegates. So probably some people liked it so much they downloaded it twice. 60,000 views. page views. It's all good, isn't it, really? And I think we have to thank Felix Strode-Allen and Rachel Cook from Crowdcoms for putting it all together. I think it's a good app, and thank you very much for that. And also for Nigel and his team for the excellent AV support we've had with very, very few glitches. Thank you very much, guys. Thank you. BAUS, it's all about people, isn't it? These are some of the people that you can recognise who've contributed. The trustees on the left, the section chairs on the right, Nigel Bullock and Jonathan, who put the website together, Veeb, and Jonathan's daughter, who does the junior curators thing on the website. And so thank you to them, and a big, big thank you to all the BAUS staff. They've worked like troopers this week, and they've done a really good job, and I think they've provided help whenever it's been necessary for anybody asking, which is fantastic. Thank you very much. Yes, yeah. I'm going to say thank you to the Lord Provost of Glasgow Convention Bureau and Visit Scotland. They made the visit here very good, very easy, seamless, very welcoming, and they're fantastic hosts. You'll all get basically an invitation to complete your detailed meeting survey. Please do so. We want criticisms, we want good things, we want bad things. Just let us know so we can shape next year's meeting. That starts on the 16th of July. The process for next year starts on the 16th of July. We start doing what we can to improve next year and perhaps replicate or modify what was successful this year. So please let us know. Any ideas, programs, themes, names, people want to get involved, just email these people. Asif Munir has taken over the Honorary Secretary, and his main job is to shape the meeting and run it next year. So if it goes well, it'll be all down to him. If it doesn't, he'll be in trouble. Next year, it's in Birmingham, so we're going to a different venue. It's right in the centre of Birmingham, right near the canals, the hotels, the bars. It's a fantastic location. Some of you remember probably BAUS 2001 when it was last there. It was very successful. One of the EAU meetings has been there as well. It's a good location. It's easy transport to get to. You're really most welcome to all come again. Spread the word about it, and just note that it's a week early. So it's the 15th to 17th of June, not the third week of June, okay? Thank you ever so much for being here. Thank you for staying to the end, and safe travels home, and see you next year.